Kia ora, ko Simon Tokuingoa. This is just a brief overview of some aspects of HIV testing, and a lot of this has already been presented by numerous people we've already heard from the very first to the most recent talks today. That one. There we go. Okay. So we all know that diagnosing people as soon as possible after the acquisition of HIV infection is very good for the person involved and also is very useful for reducing transmission. And one way that we can see how well we're doing at diagnosing people early is to look at the number of late presentations, the number of presentations with advanced HIV disease. And you can see the definitions of those there. I'll let you read those because you can read faster than I can talk. And so there are 5 publications in New Zealand looking at people with newly diagnosed HIV infection and how many or what proportion of those people are presenting with late disease, advanced disease, or an AIDS-defining illness. And you can see here that across these 5 papers, the number of people presenting late ranges between 40 and 50%, so that's a lot. The number with advanced disease ranges from 21 to 34%, so that's still a lot. And the number of people presenting with an AIDS-defining illness ranges from 7 to 20%. So obviously, at least as per these studies, there's a lot of work for us to do in being able to diagnose people sooner, more promptly. This is some work from Auckland, and what it showed was that of the people who were newly diagnosed with HIV infection, 201, that 68 or 1/3 of them had a missed opportunity for an earlier diagnosis. So if we had taken all of these missed opportunities, people could have been diagnosed a median of 12 months earlier with their HIV infection. And these missed opportunities occurred across a wide range of hospital services. Following this, we did look at the utility of an opt-out offer of HIV screening in the Auckland City Hospital Emergency Department. When we first looked at this in 2016-2017, there appeared to be borderline cost effectiveness, and this borderline cost effectiveness reduced when the number of people newly diagnosed with HIV infection fell after 2017. And there were a number of concerns from the emergency department. They didn't have the resource to take on additional workload. There was concern about who would be responsible for the positive test results. We reassured them that we would take that responsibility on. There was concern regarding the need for consent. We reassured them they didn't need to consent people. It was important for people to know what tests they're having done, and it's important for someone to know they're having an HIV test, but they don't need to be consented for that. And as well as that, what became clear was that approximately 1/3 of the people seen in emergency departments don't have a blood test for their routine care. So they come in and they have an x-ray because they've got a broken arm, or they have a tetanus shot because they've cut themselves in the garden, they need a couple of stitches. They don't have a blood test. So being able to test those people for HIV infection was going to be a hurdle. This is more work from Auckland and Northland, and this is looking at women diagnosed with HIV infection over a 12-year period. 20% of these women were diagnosed following presentation with an AIDS-defining illness, so obviously they're presenting very late. 3 of them died within 6 months of their diagnosis, and again, 1/3 of the women who were living in New Zealand before their diagnosis had identifiable healthcare interactions where we could have diagnosed their HIV infection earlier, but we missed that opportunity. So the third is the same as the previous paper. What are we currently doing in Auckland for HIV testing? Well, in terms of our engagement with the emergency department, HIV and syphilis testing is a component of all routine sexual health tests that they perform in the emergency department, so they are doing HIV and syphilis testing there. And the infectious disease and sexual health services receive weekly notification of all of these positive results so that we can support the emergency department in terms of making sure that the correct treatments are provided. We are continuing to talk with other departments in the hospital about increasing routine testing. And we have, in the adult ID service, just developed a guideline where we are routinely offering in an opt-out manner HIV screening for all the inpatients that we see and all the outpatients that we see. So every person that is being seen by the ID service at the hospital will be offered an HIV test. That's just waiting for approval from document control, but as soon as they've approved that, it'll be put into place. What do we expect to see? And previous presenters have already touched upon this, so this is stuff that we're already thinking about. What do we expect to see in terms of changes in the demographics of new HIV diagnosis as we move towards our goal of eliminating local transmission? Well, we certainly would expect that the number and proportion of those who are recently infected with HIV should fall, because those are the people that we're targeting with our strategies. With that, the proportion of those with late presentations, advanced disease, and AIDS-defining illness is likely to increase. That's not surprising. And it's possible that for a period of time, the absolute number of late presentations, advanced disease, and AIDS-defining illnesses may well remain relatively static. So with these two final bullet points, we do need to increase our efforts to identify those with more prolonged durations of infection who may well be missed by the current testing and screening strategies. And so just to illustrate the points on this slide, I've got a couple of further slides with some local data on them. Firstly, this is just an illustration of work that's being done in the community in terms of testing and the availability of antiretroviral treatment, both for treatment and prevention. And you can see there that over a 14-year period, that quite a lot of this work has occurred in the second half of the 14-year period. So we can look at data from the first 7 years and the second 6 3/4 years and see what might have happened in the changes in the demographics of the people newly diagnosed with HIV infection. And that's on this slide. So the top row is the first 7 years, the second row is the second 6 3/4 years. And you can see there that the number of new diagnoses has definitely fallen, and we'd expect that, and that's a good thing to see, and obviously that is what Sue tells us about every year. The number of late presentations has fallen. The number of people presenting with advanced HIV disease, and sorry, I forgot to tell you, this is data of people who are newly diagnosed and presenting to the Auckland ID department for their care. The number of people presenting with advanced HIV disease hasn't changed, comparing the 7 years from 2011 to 2017 to the more recent 6 3/4 years. So no change in the people presenting with advanced HIV disease, no change in the people presenting with an AIDS-defining illness. The proportions of people, as we've said, presenting with advanced disease and an AIDS-defining illness are going to increase because we're getting rid of we're preventing people with new diagnosis. Yes, we are preventing people from becoming infected currently. So that's not surprising. And with that, it's not surprising that in the more recent 6 3/4 year period, the people who are presenting have a lower CD4 count. So we really need to be finding these people here and testing them before they present with their advanced HIV disease or before they present with their AIDS-defining illness. So again, I'll just highlight that with this, we do need to increase our efforts to identify those with more prolonged durations of infection who currently are being missed by some of the current testing and screening strategies. Thank you.